Nipple/areola reconstruction. The nipple and areola are reconstructed. The physician excises graft skin, usually from the inner thigh, behind the ear, or a section excised from the patient's existing areola. The donor site is repaired with sutures. To create a new nipple, the physician excises the lower section of tissue from the patient's existing nipple or removes tissue from the ear or labia. This donor site is repaired with sutures. A thin, circular layer of surface skin is removed from the breast at the site of the graft. The areola skin graft is positioned and sutured to the breast, and the nipple graft is sutured to a small, circular incision in the areola's center. Correction of inverted nipples. Inverted nipples are corrected by making 2 or more radial incisions in the areola and elevating the inverted nipple into an everted position. Ductal channels and fibrous bands may be transected to accomplish this. Tissue may be removed. The nipple is secured with sutures and incisions in the areola are closed. Breast reconstruction, immediate or delayed, with tissue expander, including subsequent expansion. The physician performs breast reconstruction with a tissue expander, immediate or delayed. The physician makes an incision in the skin of a patient who has undergone a mastectomy. A pocket is created using an existing chest wall muscle and an expandable implant is placed into it at the site of the mastectomy. In some cases, the implant's button-shaped portal may be brought out through the skin so it is accessible by needle. Usually, the portal remains beneath the surface of the skin. The physician injects saline into the access portal to expand the implant until it has stretched the surrounding tissue to a size slightly larger than the patient's existing breast. In some cases, the expander remains a permanent prosthesis and small amount of fluid is aspirated until it duplicates the size of the existing breast. Breast reconstruction with Latissimus Dorsi Flap, without prosthetic implant. The physician performs breast reconstruction with a Latissimus Dorsi Flap. The physician transfers skin and muscle from the patient's back to the breast area to correct defects created from a previous modified radical or radical mastectomy. The physician makes a skin incision in the back and dissects a portion of the latissimus muscle and the overlying skin from surrounding structures. The muscle skin flap remains attached to a main artery. In preparation for the transfer, the mastectomy scar is excised. The muscle flap is rotated to the front of the chest through a tunnel under the armpit so that it extends through to the mastectomy incision. The incision in the back is repaired with layered closure. The physician adjusts the flap for the most aesthetic appearance and secures it with sutures to the chest wall, adjacent muscles, and skin. The incision is repaired with sutures. Breast reconstruction with free flap includes harvesting of the flap, microvascular transfer, closure of the donor site, and inset shaping the flap into a breast. The physician excises a free flap of skin, fat, and muscle from another site on the patient for use in the reconstruction of the breast following a modified radical or radical mastectomy. The free flap is excised with careful dissection of vascular channels, commonly from the thigh or buttocks, and the operative wound is sutured in a layered repair. In preparation for the graft, the mastectomy scar is excised with blood vessels preserved. The free flap is transferred to the mastectomy site and microvascular anastomosis is done to provide the graft with a viable blood supply. The physician adjusts the flap for the most aesthetic appearance and secures it with sutures to the chest wall, adjacent muscles, and skin. If the free flap does not have sufficient fat, a breast implant may be required. The chest incision is repaired with sutures. Breast reconstruction with other technique. The physician excises skin, fat, and/or muscle from another site on the patient for use in the reconstruction of the breast following a modified radical or radical mastectomy. The tissue is excised and the operative wound is sutured in a layered repair. In preparation for the graft, any mastectomy scar is excised. The tissue is transferred to the mastectomy site. The physician adjusts the flap for the most aesthetic appearance and secures it with sutures to the chest wall, adjacent muscles, and skin. An operating microscope may be employed. If the tissue does not have sufficient bulk, a breast implant may be required. The chest incision is repaired with sutures. Open periprosthetic capsulotomy, breast. An open periprosthetic capsulotomy on the breast is done by making an incision in the skin of the breast, at the site of a mastectomy scar, in the skin fold beneath the breast, or around the nipple. The physician uses a cautery knife to cut into the area of fibrous scarring associated with a breast implant. Incisions are made into the scar to cut around its circumference and enlarge the pocket in which the prosthesis is placed. Loosening the capsule relieves pain and tightness caused by the contracture. No tissue is removed. The incision is repaired with layered closure. Capsulectomy is the surgical removal of scar tissue or capsule that has become thickened and hardened around a breast implant. The capsule is composed of fibroblasts, collagen, and blood vessels. Revision of reconstructed breast. The physician makes an incision in the breast skin along the areola or at the fold under the breast or in prior surgical incisions. Tissue therein may be rearranged or secured with sutures to revise the shape of the reconstructed breast. An existing breast prosthesis may be replaced with a prosthesis of a different configuration. Excess skin or tissue from the reconstructed breast may be removed. Once the breast has been revised to its desired shape, the physician repairs the incision with layered closure. Reconstructive repair of pectus excavatum or carinatum, open. The physician performs surgery on the anterior chest to correct pectus excavatum, a depression in the chest wall, or pectus carinatum, a forward projection of the chest wall. With the patient under anesthesia, the physician makes an incision overlying the anterior sternum. This is carried deep to the bone. The costal cartilages are exposed and deformed rib ends are freed from their sternal attachments. The sternum is mobilized and restored to its normal position. Internal fixation devices are employed to hold the sternum in corrected alignment. The physician irrigates the wound and closes it in layers with sutures. Reconstruction, advancement, posterior tibial tendon with excision of accessory tarsal navicular bone, e.g., Kidner-type procedure. The physician advances the posterior tibial tendon with excision of the accessory navicular bone. The physician makes a longitudinal skin incision on the medial side of the foot from the tip of the medial malleolus to the medial cuneiform. Dissection exposes the posterior tibialis tendon. The accessory navicular is identified and removed with sharp dissection. The physician detaches the distal portion of the posterior tibialis tendon and drills a hole through the navicular. The tendon is passed through the drill hole and sutured back to itself or to surrounding periosteal tissue. Wounds are sutured closed. Reconstruction of tendon pulley, each tendon, with local tissues. With tendon or fascial graft, includes obtaining graft. The physician reconstructs a tendon pulley. The physician incises the overlying skin and dissects to the damaged pulley located in the A1 position or the distal interphalangeal joint position. In 26,500, the tendon pulley is reconstructed using neighboring tissue. In 26,502, the physician obtains a facial graft for reconstruction. Reconstruction, collateral ligament, metacarpophalangeal joint, single, with tendon or facial graft, includes obtaining graft with local tissue, e.g., adductor advancement. In a palmaris longus tendon or facial graft is obtained. The graft is sutured into place. In 26,542, an adductor tendon is advanced and sutured into place to stabilize the joint. The incision is sutured in layers. Reconstruction, collateral ligament, interphalangeal joint, single, including graft, each joint. The physician uses a graft to repair a collateral ligament of an interphalangeal joint. The physician incises the overlying the skin and dissects to the IP joint. A palmaris longus tendon or facial graft is obtained and sutured into place. To stabilize the joint, the incision is sutured in layers. Report each joint separately.